So another one of the concerns that can happen during pregnancy is the antepartum hemorrhage. Basically means after the baby comes out, there's bleeding. Any bleeding that occurs after 20 weeks gestation. Sorry, after the baby comes out. Antepartum, ante means before. So it means before the baby's born, they're being bleeding or a hemorrhage. So antepartum hemorrhage is any bleeding that occurs after 20 weeks. So this is a complication in 3 to 5% of pregnancies, and usually it's caused by placental abruption and placenta previa. So placenta previa is where the placenta is kind of laying over the cervical os, or very close to the cervical os, and it kind of disrupts the placenta, and it can cause bleeding. So a lot of blood vessels in that placenta. And other causes include other forms of abnormal placentation, like placenta accreta. That's where it's attached to like the muscle, or percreta, where it goes all the way through and attaches to like the bladder or something like that. Also ruptured uterus, genital tract lesions, and trauma can also be other causes. So some of the obstetric complications of pregnancy are most often tubal, but sometimes can be abdominal or ovarian or cervical. Ectopic pregnancies. So ectopic pregnancy, basically where the baby is supposed to land in this nice part of the uterus, but in some instances that doesn't happen. And usually it's stuck in the fallopian tubes. So usually what's going to happen, a person comes in, they've got abdominal pain, vaginal spotting, bleeding. Sometimes they don't have any symptoms though. And these etiologies can cause scarring to the fallopian tubes, can be associated with pelvic inflammatory disease, pelvic surgery, endometriosis, things like that. Differential includes, so if someone's coming in and they're complaining of this kind of pain, then you might be thinking that maybe the surgical abdomen, abortion, ovarian torsion, pelvic inflammatory disease, or ruptured ovarian cyst. Could be any one of those things. So how do you diagnose it though? So somebody comes in with abdominal pain, they've got the beta HCG levels are elevated, then you need to, of course, do the pregnancy test first, and then a transvaginal ultrasound to see if it shows an empty uterus. So if somebody has an empty uterus and they have beta HCG levels that are elevated, then you're thinking, that baby's not growing in the uterus. It might be an ectopic pregnancy. You can confirm it with the serial HCG without appropriate HCG doubling. So normally the beta HCG levels should double every 48 hours. And in the case of an ectopic pregnancy, they don't double every 48 hours. The growth is kind of restricted there in the fallopian tube. So you'll measure it on the first day, and then 48 hours later you measure it again, not doubled, and there's nothing in the uterus, then you pretty much can say there's an ectopic pregnancy. So the treatment here is going to be, if it's not very far along, you use methotrexate. Methotrexate stops cell division, and that's also if it hasn't ruptured the tube yet. But if it has, then you've got to look at maybe, if the baby's further along, or if it has ruptured the tube and the mother's blood pressure is dropping and whatnot, then you've got to think of salpingectomy or salpingostomy with evaluation for laparoscopy and laparotomy, versus laparotomy. So you might consider one of those other options, basically surgery. Tubal rupture and hemoperitoneum is an obstetric emergency. So that's for that. Next subject here is intrauterine growth restriction, or IUGR, intrauterine growth restriction. Okay, it's defined as basically less than the 10th percentile. Means something's wrong. Okay, just got to know that, and that's for the gestational age. All right, so let's look at some of these different kinds of placental abruption versus placenta previa that can go on. So, kind of comparing them, I've got a table here. So, with placental abruption, the pathophysiology here is that it's a premature separation of normally implanted placenta. So it's separated. separated placenta prematurely. Whereas placenta previa is abnormal placement of the placenta. Now I'll kind of draw what I'm talking about here. So normally, let's say here's the uterus, right? And normally the placenta, should be somewhere along this region, like over here or whatever. Sometimes, though, it can be down here. Now this is the opening, cervical os, so any sort of disruption here is going to make all this blood leak out. Sometimes it can be all the way over the top like this, and that's really bad. You have to do a C-section in that case. Even if it's close, you may have to do a C-section. So it's something you really have to watch. Placenta previa is a bad deal, dangerous deal. All right, so there's different types of placenta previa. There's total, where it's all the way over the cervical os. Cervical os means a cervical opening. There is marginal, where basically it goes partially over the margin. I guess it's over the margin of the os. Extends to the margin of the cervical os. And then there is low-lying. And this is basically where it's just really close. So to the margin of the cervical os, like here's the opening here, it's like right to the edge. And then there's the low-lying, it's like, close by, and there's total is where it's like over the top of it, So incidence of these different conditions with placental abruption, we're looking at an incidence of 1 in 100. Okay, so 1 in 100. With the instance of placenta previa, we're looking at 1 in 200. So it's more common. Placental abruption is more common. Some risk factors for these two. Risk factors for placental abruption are just things that make sense, like hypertension, abdominal pelvic trauma, tobacco or cocaine use, previous abruption, rapid decompression of overdescending uterus, excessive stimulation, all those kinds of things can cause it to rupture and bleed. Placenta previa risk factors are prior C-sections, grand multiparity, which means many babies, advanced maternal age, which usually is considered to be like over 35, multiple gestation, and prior placenta previa. Symptoms of placenta abruption are painful dark vaginal bleeding that does not spontaneously cease, abdominal pain, and fetal distress. Symptoms of placenta previa is going to be painless bright blood that often ceases in 1 to 2 hours with or without uterine contractions, usually no fetal distress. So when we're looking at the placenta abruption, this is painful, this is lots of blood, doesn't stop. When you're looking at placenta previa, we're saying light red blood, not painful, a little bit here and there. It kind of makes sense with what's happening, right? Because in placenta abruption, something is ripping apart. The placenta is ripping apart from the uterus, whereas in placenta previa, it's just over the opening, so it gets a little irritated and some blood comes out. Diagnosis. So with placenta abruption, it's a like I said, primary clinical diagnosis, which means I think they just diagnosis based on the symptoms. Transabdominal, transvaginal ultrasound sensitivity is only 50%. So you need to look for the retroplacental clot, most useful ruling out previa. With placenta abruption. With placenta previa, transabdominal, transvaginal sensitivity is 95%. So it's really easy to tell that whether someone has placenta previa by looking at the ultrasound. Management, basically, with placenta abruption, you just need to watch. Just need to watch and see, maybe some pelvic rest. If it's really, really, really bad, you may need to deliver the baby. Or maybe with a C-section. So with placenta previa, the one thing you don't want to do is perform a vaginal exam. Why? Because if this is the bottom of the uterus and this is where the placenta is sitting, and so this is cervical os, and you stick your finger in there, you stab into that placenta, now it's got a big hole in it, blood's just going to gush out. It's going to make it really bad. It's really dangerous. You're going to have to deliver by C-section. That's the That's the thing. It's going to be early, and it's going to be by C-section. Of course, with placental abruption, if the placenta is ripping away, you're really worried about a hemorrhage taking place. With placenta previa, you're looking at an increased risk of placenta accreta, vasa previa, preterm delivery, IUGR, which is, I think I was talking about earlier, the restricted growth restriction. So yeah, those kinds of things. So history, physical. Well, maybe this is actually a good place to stop on this video. I'll pick up on the next video.